Well, we have heard about quite a lot of transplantation of any organs this morning and this afternoon. We have heard about needles, we have heard about all the techniques, but never forget these children, our children, they get adults. And we have to take care about these children in terms of getting this in a serious way. So I would like to start with some definitions. What is transition? Transition is a process. What is transfer? Transfer is something, it's a moment. And compliance, or you can name it adherence, is the extent in which the patient does follow what we ask him to do in a way what matches on our agreed recommendations in terms of medication. So the question, the first one I would like to ask, why are patients non-adherent? So there are three possibilities. They have no idea, it's the first one. They know it better, or they just don't want. So these three possibilities are for non-adherence. So if you have a look at the literature and look what has been often studied in terms of adherence or non-adherence, you see that there are many diseases, disorders, from asthma to cystic fibrosis, HIV, and so on. It's not that many published, and the incidence of adherence is about 30 to 50%, and the consequences in general are that the course and the outcome is of course touched quite seriously. They can end up in a impaired quality of life, and of course it does raise the costs of all the health systems. So non-adherence after renal transplantation is quite a serious thing, is quite having a lot of consequences. The first one could be that the children are running in acute rejection, ending up in persistent tissue damage, reduced graft survival, and they had to be put on dialysis again, and they have to retransplant it again. So this is the way these children will go. And when you look at a paper that has been published 9 years ago, then you see that in these children it's about hardly half of those, they are non-adherent. About a quarter of them do have acute rejections, and about, well, 15 to 30% will have their transplant lost. And that's amazing. I mean, we can talk about new medications, we can talk about new techniques, but this is an amazing number that you see here. So the consequences you see on the left side is that we know that the green line you see is for allograft survival in patients being transplanted in the teens, in teenager age. And you see also the rejection-free survival rate on the bottom on the left side, which indicates that non-adherence does result in a lower rate. And non-adherence is something, if you look at the age, that is not with 12 or 14, it starts with 15 to 20, even 21, 22. So they do have kind of a postponed puberty they do have during their life. So what is puberty? It's a rough journey. It's all about discrepancy between dream, so what can a teenager do, what does he want to do, and what is his ability. So they do think everything is possible. No one can stop me. And this is ending in an impairment of self-reflection, reality of the awareness. So reasons, if you go a bit more in detail, as at the beginning, of non-adherence, is first that the teenagers, they have another risk behavior than we adults do have. Sexuality is an issue. They want to be peers as others. They want to just go out in the evening and have some beer or whatever. Schooling, and of course the drugs. All these issues can can lead to non-adherence. And in a chronic adolescent patient, I mean, this slide here is just for every teenager, but in a chronic adolescent patient, there is even more. They are very often to the hospital, they do depend on parents, they do depend on doctors, they do depend on nurses, and they have to cope with their chronic disorder. They are depending on the hospital the whole life. And the possible consequences, of course, are physical and mental development delay and an impairment of their family life and their social contacts. So we could ask, so what? Should we react? What should we do? I think we should react. We would like to have our small patients to become strong adults, you know, that they survive in the adult world. So what is in the literature? You all know, I'm sure, Alan Watson. He has published quite a lot on the consensus, what is necessary for a good transition, leading to a good transfer, leading to a good solution for these children. It has been published a few years ago. And the summary conclusion is that transition is a complex process leading to transfer. It goes about the information, what is including, should start very early, 12 to 14, and it should involve the parents, it should involve all the teams, and it should also involve the peers, the schooling, and everyone. And the adolescent does need the individual schedule to be known. He does, or she does, to get to know what's going on. There are also skills and competencies described what a patient, when getting adult, should be know about. So you can read it on the right. It's just the understanding of risk behavior, the understanding of the disorder, the understanding of easy things, how to make up an appointment, how to contact, at Saturday morning when I'm not feeling good. So what is or has to be involved is the patient, with the family, with the peer support, it's the pediatric unit, it's the adult unit, and in between there is some coordinator, some nurse, some psychologist, or you just name it, transition coordinator. So having a look at this concept, what is resulting in Europe, there has been published a survey last year, an online survey, including hardly 40 centers from 24 European countries, and they've tried to give a score to this kind of recommendation. What is the result in 3 centers? It's also a solution. I don't think it's good that pediatrics should stay in the pediatric setting, even if they, getting adults. In 5 centers there was no transition, and in the remaining centers they only get a median score for adherence. The maximum here was 15, and they reached in median a score of 10, which is, I think, not that good. What about the United States? They also did a survey questioning what is the handling with these patients. They get about a response rate of 40%, and what they saw that there is an inconsistent use of validated tools that are known, insufficient communication, the lack of use of dedicated tools. So they worked out the development of rise to transition. I'm sure you know this. These issues, and there are described 4 competency areas, as you can see here: recognition, insight, self-reliance, and establishment of healthy habits. And they end up, you can't read it, I'm sorry for that, but they end up in a just a schedule how to go through this time with the patients. So transition around the world is the issue I've been asked. It's not much published. The question is why? Because it's not consequently implemented, because you don't get famous, you get more famous publishing some new genes. That's just a matter of fact. You can't change that. It's expensive or maybe not needed. As a few of you possibly know, I'm also working in Cambodia. This is the emergency room in Cambodia. It's just 500 children being there. The rest is waiting outside, you know, waiting on the streets during nights. Some of those, they will die. So they're just happy to have an X-ray. And this may introduce peritoneal dialysis. So there is no need of a transition program in these countries, okay? So what have we done in Zurich? We do have a adherence and a transition program. It starts at 7 years, the adherence program. There is individual training, supportive tools, and we have a transition program which then starts at 14, including also a individual support. In detail, it's the adherence is getting taught by a nurse and the leading doctor. We have handouts, we have folders, we discuss these things. We have supportive tools. We had in earlier times a watch, you know, giving 2 alarms every 24 hours. And nowadays, of course, we have the mobiles. We have developed an app with information, with alarms when you don't take the medication 10 minutes after. We have these boxes. We have candy boxes because if the teenagers, you know, they are at Saturday evening, they are not at home. They are with the peers. They don't want to be recognized as a drug dealer because they just have the medication. They just take it out of a candy box. Just simple things. We have events, workshops for patients, parents, teachers. We have a dialysis camp. See the Swiss Mountains and the transplant groups. We have adherence training. And we try to find out when a patient is non-compliant or non-adherent. So we assume if he's lacking, his outpatient clinic is having unstable drug levels, missing appointments, and all these things, that there are kind of consequences then. So we do intensify the adherence program. We make weekly appointments and try to optimize. The schedule is with 14. We ask the parents to be out of the room, which is not always that easy. We switch from, sorry, this is German, from du zum sie. We Swiss and German, we are a bit stupid. You is not you. There is a polite form of you, and this is the sie. I hope you get that point. But this is making you adult, okay? So we start to plan the transfer individually. Some are with 18, some with 19 or with 20, they are ready. And then 1 year before transfer, we just make a detailed schedule. We just repeat all the things. We just talk about all these issues that you can read here. And I've already also mentioned, we do include other experts, social workers, and other specialists, dietitians, psychologists. And then there is 1 day per year we do a transfer. We discuss, we meet in the group, and then we physically walk to the adult center. And in the adult center, they just get informed, they get to know who's my new doctor and stuff like this, okay? And the question of course, is it worth it? It's quite a lot of work. It costs as well, and as I mentioned, you don't get famous. So we did a retrospective cohort study. We just historically looked what happened before, what happened with this transition and compliance or adherence program, and published this 3-4 years ago. And the results are, we had 2 groups. The one in pink is transition group without, and on the right one, the orange one, is with. And you see it's not a huge number. Zurich is not a huge center. You see these groups are comparable. There are the 2 things you see now, the living organ donation and the age was significant, not to compare, but I think this not changed the result. And what we saw and what the primary outcomes were is that after the transition 1, 2, or 3 years, you see that there is a better GFR in the group with transition program, and we had less rejection rates. Of course, the number is low, I know. And you see here again the group without transition program ending up in a more severe or higher percentage rejection rate as the one with transition program. So the conclusion, it improves GFR, it reduces the incidence of acute rejection, and I think it's worth it investigating in these children. So to summarize, I think it's transition that is some individual process ending up in transfer. We can't do it better than adults, and adults can't do it better than pediatricians. That's important to realize. And it demands collaboration, and it reflects, by the end of the day, the pediatric quality of work. So let me finish with this slide. I mean, these children and adults, if you ask them, they have one wish. They just want to be normal. They just want to be normal. They want to go play football. They want to go away in the evening with the peers. They want to go in school. Just want to be normal. And I think we should help them to reach this tool and to reach this aim of just normality. Thank you.
Thank you, Guido, for a fantastic talk and a really good overview of transition and how it's done in other countries. Any questions?
First of all, great subject. But one thing, pediatrics do better than adults, I'm sorry.
Pediatrics do better than adults?
We're doing adults better.
I mean, if you say that.
No, not just.
No.
I think that the patients, pediatric patients, when they go to adult, the main thing they tell us is that the intensity of the follow-up by the APPs and the transplant is much more intense. And much. If they don't show up to lab, they're calling them. Why not? Adults, if you don't do it, you don't do it.
Yes.
Number two is education. We have an extremely intense education program because they need to have a job. After 18, if they don't have a job, they don't have insurance. And that's one of the most important aspects we lose grasp, is financial. And third is the aspect of cognitive development. As you know, a lot of metabolic diseases impact the brain, and it's mostly a frontal lobe. God forbid I start smoking pot. So we probably should be careful with how we transition. We have lost a patient just recently because parents said, you're 18 years old, you're on your own, you have to take your medication. But the cognitive function due to the MMA was not there. And essentially he ended up losing everything in his life. So thank you, good representation.
Yeah, I mean, this is a special group you mentioned, the group with the mental delay. This is one thing I really could only underline. And the other thing, of course, it is also quite important to have these patients, these adults, to be socially integrated by having a profession. By this is one of the skills they should have. I mean, if you study, you can't wait till then to be to have transition. But you need to have a profession. You have to be settled down in what you're doing, even if it's still being on education. But we also have a group, trying to organize, to help, to make the network that they find a good solution in terms of schooling and profession.
That's important, that even if they don't go to college, they have a skill.
Yeah.
Just before we close, just like a comment from Gronya, who's an advanced nurse practitioner in transplantation at Evelina. I know that he has an enormous experience in successfully transitioning children, so I think it would be good to just hear from her and her view on how to successfully transition those children.
I wish we had the magic answer. Thank you very much for that presentation and for raising such an important topic. But I think it's so important to see the collaboration, and certainly the GOS team and us at Evelina London have seen that by collaborating with our adult colleagues, it's definitely the way to, or the direction to move, so that our young adults can see trust between the teams, the adults and the paediatrics working together. And there isn't a quick fix, but it's about continuing and handling the failures as well as the successes on the way. So thank you.
Thank you. I mean, yes, we could learn from each other, as I have learned from the adults. I think they learned from us. And in earlier days, it was always the message, well, you can't care about these patients because you don't know about cystinosis or you don't know about primary hyperoxaluria. But of course they don't, maybe really they don't know because we don't teach each other. And that's, I think, also a very good point, that we collaborate, that we take part of each other's professional life.
That was excellent, Guido. I was just going to ask very quickly, do you have a youth worker? Because I think we've got experience in working with some of the adult teams where I think the youth worker really adds a different dimension, because the young adults actually will tell the youth workers things they might not tell the nursing and medical staff as well.
Yes.
Thank you very much.